Good morning. This is Follow the Science Monday COVID-19 update. I'm Dr. Paul Juarez, Professor and Vice Chair for Research in the Department of Family and Community Medicine at Meharry Medical College and Principal Investigator of the Tennessee Community Engaged Alliance Against COVID-19, also known as Tennessee SEAL, and Project Site PI for HealthWorks, a HRSA-funded COVID prevention program established through a subaward with the Morehouse School of Medicine. Today is Monday, November 21st, 2022. Over half the cases of COVID-19 in the United States are now due to two descendants of the BA.5 Omicron variant called BQ.1 and BQ.1.1. While not much is yet known about how these two variants, the severity and duration of disease seems similar to the other Omicrons, and milder than the original and Delta variants. The biggest challenge from the new variants are for people who are immunocompromised because of disease or medications. Treatments designed to prevent and treat infection in the immunocompromised won't work against BQ.1 and BQ.1.1. Today, I'm going to provide an update of where we are with COVID-19 and long COVID. Then I'm going to provide an update on the status of clinical trials of a combined COVID-19 flu vaccine. I will conclude with an update of the number of new cases, hospitalizations, and deaths, both nationally and in Tennessee. New cases and hospitalizations due to COVID-19 remain relatively flat over the past 2 weeks, while deaths continue to decline. While in general, current COVID-19 variants no longer appear to be a significant threat of severe illness or death for a majority of people, it still should be considered dangerous for persons in high-risk groups, including for persons over 65, those with multiple chronic diseases like heart disease and diabetes, and those who are immunocompromised. As people spend more time indoors, the CDC is warning against a possible new surge in cases and is strongly recommending that people get the new bivalent booster. And while the short-term effects of COVID appear to have lessened due to the high percentage of the population that has some level of immunity against it, either due to vaccination or prior infection, there is increasing evidence that we should also be concerned about the long-term effects of COVID-19, not only on the respiratory system and organs, but on the brain and neurological systems. There is growing evidence that cognitive deficit from neuroinflammation may result from even mild COVID-19 symptoms. Millions of people who have had COVID-19 continue to experience or develop new symptoms for weeks, months, or years after they were first infected. These symptoms are commonly known as long COVID. In a study supported by the National Institute of Neurological Disease and Stroke and the National Institute on Deafness and Other Communication Disorders, researchers looked at the effect of SARS-CoV-2 infection in animal models to understand potential causes of long COVID. Their findings suggest that in addition to causing long-lasting organ damage, SARS-CoV-2 can set off a pattern of brain inflammation that may be linked to long COVID-19 symptoms. The research shows that even a mild case of COVID-19 that affects the respiratory system can cause long-term changes to how brain cells work. This would explain why some people report having problems with thinking and memory, often called memory fog or brain fog, after COVID-19. A new study by French researchers published in JAMA Network Open on 1-year rates of long COVID found that among about 4,000 people who tested positive for SARS-CoV-2, about a third said they had at least one COVID-19 symptom for 2 months or longer. Risk factors for lingering symptoms were age older than 60 years, female sex, a history of cancer or tobacco use, obesity, and more than 4 symptoms during infection. Among participants who had symptomatic infections, an estimated one-third had more than 5 symptoms 1 week after infection, falling to 2.8% at 2 months. An estimated 97.5% of participants with weakness, 94.2% of those with impaired attention or concentration, and 77.5% of those with memory loss reported symptom resolution at 1 year. The most common long COVID symptoms were memory loss at about 40%, sleep disorders at 36.6%, shortness of breath at 26.5%, joint pain at 26.9%, loss of taste at 27%, weakness at 20.6%, and impaired attention or concentration at 22.3%. In general, women were slower to recover their sense of taste or smell. Older people, women, and those with a history of anxiety or depression, cancer, diabetes, tobacco use, obesity, or a higher number of acute symptoms were slower to recover from weakness. Slow resolution of impaired attention or concentration was tied only to older age. 2 other studies presented this week at the Society for Neuroscience annual meeting in San Diego found that profound brain damage can linger for months after COVID-19 infection. In one study, Mexican researchers used functional magnetic resonance imaging, or fMRI, to assess the sensory motor brain region of 240 children 10 to 13 years of age infected with SARS-CoV-2 in the previous 4 to 15 months. Relative to controls, COVID-19 patients required more resources in 3 areas of the brain. In a second study, Brazilian scientists using MRI and positive emission tomography, or PET, imaging found that about a quarter of adults who had mild COVID-19 had impaired ability to coordinate their fine motor skills and spatial abilities 4 months after infection. The findings were associated with molecular and clinical changes in the brain. Although these are preliminary data, findings suggest that cognitive deficit from neuroinflammation may result from even mild COVID-19 symptoms. Researchers said that while SARS-CoV-2 doesn't directly enter the brain, it can still cause long-term brain function changes through inflammation. Next, I'm going to provide a brief update on efforts to develop a combined vaccine for both COVID-19 and the flu. While there are no approved flu vaccines with mRNA technology, both Pfizer and Moderna vaccine developers are working on it. They are also working on developing a single vaccine that offers strong protection against both viruses. Vaccine developers are using their candidate flu vaccines that use mRNA technology and combining it with their bivalent booster. The combination vaccines induce an immune response specific to the 4 strains of flu circulating that season: the original coronavirus and the BA4, BA5 Omicron subvariants. Both companies have recently begun clinical trials to assess the efficacy and dosage of their candidate vaccine that combines 4 flu strains and 2 coronavirus strains. This month, Pfizer announced the start of phase 1 trials to evaluate the safety, efficacy, and optimal dose level of its combination candidate vaccine and began enrolling participants. Researchers will follow up with participants after 6 months, the company said in a statement. Moderna is slightly ahead. It already has its phase 1-2 trial fully enrolled with participants ages 18 to 75. The flu COVID candidate vaccine combines Moderna's original COVID-19 mRNA vaccine with its candidate mRNA flu vaccine, which is also in phase 3 trials. Health experts say these combination vaccines should be available as early as next flu season. Nationally, reports of new cases have been roughly flat in the past 2 weeks, though rising test positivity suggests that that may not stay that way. Test positivity is up nationally by 4%. Recent hospitalizations have also been flat at the national level. By contrast, daily deaths from the coronavirus are decreasing. Death counts have fallen by 13% nationally in the past 2 weeks to about 285 per day, the first time they have been under 300 in a number of months. In Tennessee, the number of new reported cases of COVID-19 are down 8% over the past 14 days after a spike 2 weeks previously. Hospitalizations, meanwhile, are up 3% to 420 per day, and deaths are flat at 5.4 per day, or 0.08 per 100,000 of the population. And test positivity is at 9%. When test positivity is above 5%, transmission is considered uncontrolled. There is little change in community risk level from 2 weeks ago. There currently is one county in Tennessee in the red zone, and that is Sullivan County in northeastern Tennessee. In addition, there are 8 counties in the yellow zone, the same as 2 weeks ago. 5 are in East Tennessee and 3 are in Southeast Tennessee. Counties in East Tennessee that are in the yellow zone include Carter, Washington, Hancock, Hawkins, Scott, and Monroe. Lincoln, Van Buren, and Polk counties in the southeastern region of the state are in the yellow zone, while the remaining 86 counties are in the green zone. For now, this is Dr. Paul Juarez from Tennessee SEAL and HealthWorks, wishing you a good day, a happy Thanksgiving. Be safe.